Hi, my name is Trevor Green. I'm a patient navigator with McLaren Physician Partners, and this is a presentation on improving patient satisfaction through GPRO opportunities. In order to improve patient satisfaction and outcomes, we had to identify places in care that we noticed that can be improved. And one of those is high blood pressure. Nearly half the adults in the United States have hypertension, defined as a systolic blood pressure greater than or equal to 130, or diastolic blood pressure greater than or equal to 80, or are taking medication for hypertension. As a patient navigator, an observation that I've made while extracting patient information for GPRO is that when a patient goes to see a provider, providers are rarely performing blood pressure rechecks when a patient's initial blood pressure is above the 140/80 threshold. This leads to unneeded ED visits and readmissions to the hospital. So you may be asking yourself, what can we do to improve these numbers? Providers can improve quality numbers and overall patient care with a focus on this issue. What needs to change? We need to standardize blood pressure readings so that patients are receiving correct care from their providers. And there are many factors that can go into a high initial blood pressure reading. And to overcome these skewed readings, providers must begin doing blood pressure rechecks, no matter what the case, when a patient's initial blood pressure reading is over 140/80. Both or more, if you have to do 2, 3, 4 readings, must be documented in the patient's chart. So how will the rechecks help? Not only will this improve patient care or reduce patient visits, but it will also help us on the quality side of things. When extracting data for GPRO, a blood pressure value greater than or equal to 140/90 will remove a patient from our population and negatively affect our audit. When performing rechecks, patient's blood pressure will not always fall below our threshold. However, a recheck will not only help us in the long run, but it'll also help the providers improve patient care and remove the need for the patient to rush to the ED or urgent care back to their PCP due to blood pressure concerns. This will also, in the long run, take down patient readmissions or admissions to the hospital due to blood pressure concerns. The next GPRO measure where we can improve patient outcomes and satisfaction is Prev 13, which is the ASCVD in the use of statin therapy. About one person dies every 37 seconds in the United States from cardiovascular disease. In order to combat these diseases, many providers provide statin therapy to reduce risk and keep the patient healthy. When extracting patient information for the Prev 13 measure in GPRO, there are many steps that go into finding if a patient is receiving statin therapy. First, we need to recognize if the patient is currently or formerly diagnosed with any form of ASCVD. Second, if the patient has no history of ASCVD, LDL-C values are looked at to see if the patient has hypercholesterolemia. Here lies the problem. There are many patients in our population that do not fit this measure. It is not because they don't fit the value, but due to a simple issue of verbiage. When a patient's LDL-C level is over a certain level, the patient is normally diagnosed with hypercholesterolemia and put on a statin. However, after reassessing our team's observations, I realized many patients fall into this population. If that's the case, then why are our quality numbers for ASCVD and statin therapy going down? The answer lies in the diagnosis being used to notate high cholesterol. Hyperlipidemia is the presence of high levels of fats in the blood. The two major types of lipids found in the blood are cholesterol and triglycerides. Hypercholesterolemia, also called high cholesterol, is a medical term for abnormally high levels of cholesterol in the blood. It is the similarity in diagnosis that is driving our numbers down. CMS does not permit us to use hyperlipidemia as a diagnosis for this measure. When a patient has high cholesterol but normal triglycerides, providers are not using hypercholesterolemia, but they are still only using that hyperlipidemia diagnosis. MPP's 2018 Prev 13 performance rate was 79.54. The following year, the performance rate was 74.29. That's a decrease of more than 5%. Now, looking at this, you may think 5% is not a huge decrease. However, this is the difference between us hitting a larger percentile overall and hitting the individual measure benchmark set for us. If we could get our physicians to universally switch to hypercholesterolemia, our GPRO population would be much smaller and more compliant, leading to higher performance rates overall and the ability to hit higher individual benchmarks. Many patients that we cannot put into the population because of these issues are actually on that statin therapy. However, we cannot use this patient's information because of this minor vocabulary discrepancy that takes them out of our population. In conclusion, if we can make these changes discussed in this presentation, not only will our patients' quality of care increase, meaning high blood pressure trips to the ED less frequently, accurate blood pressure readings lead to correct medication regimen, etc., but also MPP's GPRO performance ratings will go up. Thank you for your time, and I hope you have a great day.